Now we will study the actions of the extraocular muscles. The extraocular muscles, they are responsible for the movements of the eyeball. And movements of the eyeball, they are possible along the three axes. That is, one is this vertical axis shown by blue, second a transverse axis shown by red, and third an antero-posterior axis shown by green color. Now, along the vertical axis, the eyeball either can move medially or laterally around the vertical axis. The medial movement is named as the medial rotation or adduction, and lateral movement is the lateral rotation or abduction, as shown by in the first set of eyes, the adduction and abduction. While along the transverse axis, the eyeball can move either upward or downward. Upward movement is the elevation, and downward rotation, it is termed as the depression, as shown by the second set of eyes, the elevation and depression. Now these two set of movements, adduction, abduction, elevation and depression, they are described in terms of the direction of movement of the center of the pupil. That is, if center of pupil moves medially, adduction; if laterally, abduction; upward, elevation, and downward, it is the depression. Third set of movements in the eyeball, they are possible along the antero-posterior axis. Along the antero-posterior axis, the movements, they are described in terms of the movement of the upper margin of the pupil. And upper, we have marked the 12 o'clock position at the upper margin, and if the pupil from this 12 o'clock position, it moves medially, it is termed as the intorsion, and if it moves laterally, it is termed as the extorsion. As we can see in the third set of eyes, the movement of upper margin of the pupil from 12 o'clock position medially, intorsion, and laterally, extorsion. So these are the three set of movements possible along the three axes. First is the vertical axis. Along the vertical axis, adduction and abduction. Along the transverse axis, elevation and depression. And along the antero-posterior axis, intorsion and extorsion. Only the third set of movements, they are described in terms of the movement of the upper margin of pupil from 12 o'clock position. The muscles which are responsible for these three set of movements, they are recti and the oblique muscles. Now we will study how these recti and oblique muscles, they function and how they differ in their mode of action. Now in this first set of eyes, we can see a superior rectus muscle. As we know, all the recti muscle, they are inserted at the anterior pole of the eyes, or we say they are inserted anterior to equator. So these recti muscles, which are state muscle, they will always move the anterior pole of the eyes. As we can see in this first set of diagram, the superior rectus muscle from common tendinous ring to the anterior pole. Whenever this superior rectus, it contracts, it pull the anterior pole upward. So this will help in the elevation of the eyeball. Similarly, the inferior rectus will pull it downward and it will help in depression, and same is for the medial and lateral rectus. Medial rectus will pull the eyeball medially causing adduction, and lateral rectus will pull the eyeball laterally causing the abduction or lateral rotation. So these recti muscle, they will function according to their name, since they are inserted near the anterior pole and they will move the anterior pole of the eye. But the oblique muscles, as we see in this second set of diagrams, superior oblique has been shown, which takes origin from body of sphenoid, reaches near roof of the orbit and is inserted at the posterior pole of the eye, or we say that it is inserted behind the equator. So superior oblique muscle, whenever it will contract, it will pull the posterior pole upward, as in this second diagram. So superior oblique, when contracts, it is pulling the posterior pole upward, and the movement which you actually see, it is the depression of the eyeball. So this is the difference in the action of the recti and oblique. Recti will always function near the anterior pole, but superior oblique muscles, they will always pull the posterior pole. since it is superior oblique, as it is superior in position, so named superior oblique, but it will actually cause the depression of the eyeball by pulling the posterior pole upward. Now, similarly, we can compare the actions of inferior rectus and inferior oblique. This is the inferior rectus inserted near the anterior pole, anterior to equator. Whenever inferior rectus it contracts, it pulls this anterior pole downwards, and the movement it does, it is the depression of the eyeball. Now look at the second set of diagrams in which the action of inferior obliques are shown. The inferior oblique muscle, which is present at the floor of the orbit and inserted at posterior pole. So whenever it will contract, it will pull the posterior pole downward, and movement which you actually see, it is the elevation of the eyeball. So now we are clear about the difference in the actions of the recti and the oblique muscles. Recti, they will always move the anterior pole, while obliques, they will move the posterior pole. So if we say elevation of the eyeball, as we see in this second set of eyes, elevation of the eyeball will be done by the two muscles. First is this inferior oblique, and elevation is also done by the superior rectus muscle. Similarly, in the first set of eyes, the depression of the eyeball can be done by two muscles. First, inferior rectus, and second muscle responsible for depression, it is the superior oblique muscles. So that is how the recti and oblique muscles they work and how they differ in their action. The oblique muscles, they will always lift or depress the posterior pole, and they will act opposite to their name. Superior oblique will do the depression, and inferior oblique will do the elevation of the eyeball. We can see in this next diagram, we have just written the movements. The elevation done by superior rectus and inferior oblique, depression is done by inferior rectus and the superior oblique, and this movement is possible along the transverse axis, upward rotation and downward rotation. While the adduction movement will be done by medial rectus, and abduction movement will be done by the lateral rectus along a vertical axis. So these are the moves, two set of movements possible along the vertical and the transverse axis. The third set of movements, they are possible along the antero-posterior axis. Along the antero-posterior axis, the upper margin of the pupil from 12 o'clock position, it will move medially or laterally. The medial movement from this 12 o'clock position is the intorsion, and the intorsion will be done by the muscles which are present superiorly, that are the superior oblique and superior rectus. While the extorsion movement, it will be done by the inferior muscles, the inferior rectus and inferior oblique muscles. So that is the third set of movements possible along the antero-posterior axis. Now we know that the in this diagram we can see the elevation and depression. The elevation, it is done by superior rectus and inferior oblique, while depression it is done by the inferior rectus and superior oblique. Now we will study with the next slides how these two type of muscles which are responsible for elevation and depression, they differ in their action. As we see in the next diagram, we have drawn the position of the eyeball in three sets. First is the primary position of the eyeball when we are looking forward. With the red color, this is the visual axis. Visual axis means an imaginary line which is passing through the center of the anterior pole and the center of the posterior pole. Second eyes, they are showing the abducted or laterally rotated position of the eyeball. And third is the adducted or medially rotated position of the eyeball. Now in the second set of eyes, the oblique muscles and recti muscles, they are shown, and in this the neutral or primary position is shown. In the second set of eyes, where there is abducted position of eyeball is seen, and we can see that the recti muscles, they are actually corresponding with the visual axis at this point. that is the axis of the recti muscle. If we draw the axis of the recti muscles, we can draw with the yellow color the axis of the recti muscle. So now the visual axis is actually corresponding to the axis of the recti muscle. So if a extraocular muscle it is present along the visual axis at any position, it will do that action maximum. So the recti muscle, they will act maximum during the abducted position as their axis is coinciding with the visual axis in this position. And if we compare it with the next set of the diagrams where there is adducted position of the eyeball or medially rotated position of the eyeball, and now if we draw the axis of the oblique muscles with the yellow, this is the axis of the oblique muscle. Now this axis is coinciding with the visual axis at this point. So that means that the oblique muscles, they will act maximally during the adducted position of the eyeball. So this will be the difference in the action of the oblique and the recti muscle. That is, the recti, they will act maximally during the abduction or laterally rotated position. That means that they will do elevation and depression in the laterally rotated eye, while the oblique muscles, they will do depression and elevation during the medially rotated and adducted eye. So we should always remember that the when the axis of the recti axis of a muscle it corresponds to the visual axis, it will act maximally. So by this, we are clear about the difference in the action of the recti and the oblique muscles, and why recti muscle they cannot behave properly in the adducted position. We can see in this slide, first is the abducted position, second primary, and third is the adducted position. So as the eyeball it moves from the lateral to primary position and then to medially rotated position, the recti muscle which were maximally taut or contracted in the laterally position, they become loose and lax when the eye is medially rotated, so they cannot function maximally in the adducted position. So when the muscle recti it is in the laterally rotated eye, it will act maximally. So we can say now the in the abducted eye, elevation and depression, they are done by superior rectus and inferior rectus, but in adducted eye, elevation is done by inferior oblique and depression is done by the superior oblique. So we have discussed the laterally rotated and medially rotated eye and how the oblique and recti muscle they will act in these positions. But if the eyeball is in the primary position, this is the primary position when we are looking forward, and in the first set of eye we have drawn the recti muscle, in the second the oblique muscles. In the primary position, the recti muscle, when they contract, they will pull the anterior pole medially. So they will be actually causing adduction at the primary position, and the oblique muscles, if we see, when they contract during the new primary position, they will pull the posterior pole medially, and the movement which we will see, it is the abduction. So these two things we must remember, that the during the primary position the adduction is also a function of recti muscle, but in primary position the obliques they will do the abduction. And now if we revise all the movements which we have studied, the superior rectus and inferior rectus, they will do elevation and depression in the abducted position, as we can see in this slide, as their axis is coinciding with the visual axis at this time. But superior oblique and inferior oblique, they will do the depression and elevation in the adducted position, as axis of the oblique muscles is coinciding with the visual axis at this position. But in primary position of the eyeball, which is shown by these lower set of eyes, the recti muscle, they will help in adduction by pulling the anterior pole medially, and the oblique muscle, they pull the posterior pole medially. So from the primary position, they will actually do the abduction movements. So by this chart, we are now clear that in neutral or primary position, the adduction is the function of superior rectus, medial rectus, and inferior rectus, while abduction or lateral rotation, it is a function of inferior oblique, lateral rectus, and the superior oblique muscles. So this is how the oblique and recti muscle they work during the various movements of the eye. And the along the vertical axis, we have seen the movements which are possible. They are adduction and abduction. Along the transverse axis, elevation and depression. And along the antero-posterior axis, intorsion and extorsion movements, they are possible. Now, muscles of the both the eyes, they work in a coordinated and conjugated manner. Like we can see in the first number of eyes, when the patient is asked to look left and upward, we can see in the right eye is medial and upward. So medial and upward, it is a function of inferior oblique, but in the left eye, it is lateral and upward, which is a function of the recti muscle, which act maximally during the abducted position. So right inferior oblique and left superior rectus, they are functioning in a coordinated manner so that we can look upward and towards the left. In the second set of eyes, number 2, when the patient is asked to look downward and towards the left, we can see in the first right eye, it is the medial and downward, which is a function of superior oblique, while in the left eye, it is lateral and downward, which is a function of the inferior rectus. Similarly, if from the neutral position, patient is asked just to look towards the left side, right medial rectus will function and left lateral rectus will function. So the extraocular muscles of the two eyes, they behave in a coordinated and conjugated manner so that a binocular single vision is possible. If they do not behave in this coordinated manner, the patient will have a squint or strabismus condition in which a single image formation is not possible, and patient can have diplopia or double vision. And if we have to test these extraocular muscles, so in this chart, we can see how we can test the various muscles. Since the recti muscle, they are functioning best in the laterally rotated position. So in this movement, we will ask the patient first to look laterally and then upward or downward to test the superior rectus and inferior rectus respectively. Similarly, in the last set of the eyes where we want to test the inferior and superior oblique, patient will be first asked to look medially and upward or downward respectively to test the oblique muscles as they are functioning maximally in adducted position. If one has to test the lateral rectus and medial rectus, the patient is simply asked to look towards the lateral side or medial side from the neutral position, so we can test these lateral and the medial rectus. So we have studied about the movements of the done by the extraocular muscles in the eyeball, and now we are clear that the recti muscle, they can function maximally elevation and depression in the laterally rotated eye, while the obliques, they will do their function maximally in the medially rotated eyes. So that is about the movements and actions of the various extraocular muscles. Now the applied anatomy related to the extraocular muscles, we have already studied about the levator muscles. The levator palpebrae superioris, it is responsible for the elevation of the upper eyelid, and if there is a dysfunction of the levator palpebrae muscle or involvement of the third nerve, the patient can have ptosis or dropping of the upper eyelid. Cause of the ptosis can be either congenitally, or there can be weakness of the levator muscle due to myasthenia gravis, or oculomotor nerve can be involved in head injuries or infection. But Partial ptosis is another condition associated with levator muscle when the only Mueller's fiber or involuntary part of levator is involved. In this condition, the sympathetic fibers which are supplying the Mueller's muscle, they can be involved, and this is usually a part of the Horner syndrome. Cause can be congenital, traumatic, or it can be secondary to the carcinoma of the lung. So this is the applied related to the weakness of the levator muscle or injury to the oculomotor nerve. Other conditions which can be associated with movements is the squint or strabismus. As we know that we have a binocular single image formed by the brain. The brain combines the signals from the two eyes and form a single three-dimensional image. And in cases of the squint, the two eyes, they are pointing towards the different directions, so it is not possible to form a single image, and the patient can have diplopia. Causes of the squint can be either congenital or it can be acquired. The difference between the congenital and acquired squint is that in the congenital variety, the patient will not have any diplopia because the brain will slowly learn to ignore the signals from the eyes, which is offline, and a single image will be formed by the brain, and patient will not have a diplopia. But if the squint is acquired later in the life, that is the paralytic type of squint, the patient will have diplopia. And this squint can be either damage to the abducent nerve when the lateral rectus is paralyzed. And in the second picture, we can show the eye will be medially rotated and the patient is said to have the medial type of squint as lateral rectus is not functioning. While damage to the oculomotor nerve can result in damage to the nerve supply of medial rectus, and patient will have lateral squint as in the third diagram, and associated with this ptosis will be there due to involvement of levator muscle. While the damage to the trochlear nerve, that is the superior, which supplies the superior oblique muscle, the patient will have the diplopia, as the trochlear nerve superior oblique is responsible for the depression during the medial position. So patient is will complain of the diplopia when he is looking downward, especially when he is moving downstairs. So these are some of the applied anatomy related with the movements of the extraocular muscles. The other condition which can be associated can be the nystagmus. In the nystagmus, there is involuntary and rhythmic oscillatory movements of the eyeball. And these oscillatory movements, they are due to incoordination of the ocular muscles. The cause can be either congenital, vestibular, or cerebellar. As we see in this picture, there is a rhythmic and oscillatory but involuntary movement of the eyeball, and cause is the either congenital, vestibular, or cerebellar. So that is about the movements of the extraocular muscles and the disease related to them. Just to summarize, the orbits, which are the four-sided pyramidal bony depressions in the anterior part of the facial skeleton, and they lodges the eyeball along with its muscles, vessels, and nerves. And in the eyeball, the muscles, they are either straight, four recti muscles, or muscles can be oblique, superior and inferior oblique. The recti, they move the anterior pole, while the obliques, they move the posterior pole of the eye. So that completes the topic about the orbit and the extraocular muscles. Thank you.